Imagine standing on the edge of a busy urban intersection.
Just a normal day.
Right, exactly. The ambient noise is just the standard hum of modern life. Engines idling, footsteps on the
The
pavement.
distant wail of a siren, maybe.
Yeah, and then suddenly that entire auditory landscape just shatters. You hear this violent, high-pitched screech of tires locking against the asphalt.
Followed by the crush of metal.
Yeah, that heavy resonant crush of metal deforming under just immense kinetic energy. And then comes that sudden heavy silence that always seems to follow a collision.
It's a very visceral reminder.
It really is. It reminds us that our modern world, the roads, the railways, the skies, the sea routes, they all carry this inherent ever-present risk. When motion, momentum, and mortality intersect, the human body ceases to be just biology.
It becomes a biomechanical record of force.
A biomechanical record. I love that phrasing. Welcome to this deep dive.
Thanks for having me. I'm excited to get into this.
Today, our mission is to extract the absolute most critical, high-yield medico-legal insights from a foundational text. We are looking at Simpson's Forensic Medicine, specifically Chapter 19.
Which covers transportation medicine.
Yes.
Right.
We're going to unpack that intersection of anatomy and velocity and explore how high-energy transfer creates these very characteristic, predictable injury patterns.
But before we get too deep into the clinical details, we really need to issue a crucial disclaimer here.
Oh, absolutely.
We are speaking directly to you, the medical students preparing for your board exams, the junior doctors revisiting your medico-legal principles, and the senior clinicians refining your frameworks.
Right. This deep dive is a conceptual exploration to support your studies. It is not, and I cannot stress this enough, it is not a regurgitation or a replacement for reading the actual text.
No, definitely not. You should be using this discussion right alongside your reading of Chapter 19. Use this to anchor the concepts, understand the underlying physiology, and build up that pattern recognition.
Exactly, because knowledge is most valuable when it's understood conceptually, not just memorized from a list.
We want to connect the mechanism of injury to the interpretation of that injury, and then to the legal implication. Transportation medicine is literally where physics meets anatomy.
And where reconstruction has to be grounded in evidence. So let's start by laying the groundwork with the rule book. Section 1, the medico-legal framework in toxicology.
Or, as we can think of it, transportation under the influence.
Right. So the legal frameworks for moving a multi-ton vehicle basically operate on two distinct levels. You have the personal level.
Which is what we're all familiar with. Speed limits, traffic lights, intoxication thresholds.
Exactly. But then there's the corporate level. And this is where we see some really fascinating shifts in legal philosophy, especially in the UK with the Corporate Manslaughter and Corporate Homicide Act of 2007.
The evolution of that corporate law is actually profound.
Yeah.
If you look at the history of transport disasters, say a ferry capsizes or a train derails historically, the legal focus was almost entirely on the individual operator.
The driver or the captain.
Right. The investigation would just ask, did this specific person make a fatal error? But what the 2007 Act recognized is that systemic failures are often the true culprits.
So gross negligence across a whole company.
Exactly. A corporate entity's failure in health and safety management can have fatal consequences that completely outweigh one single driver's mistake.
Because, a driver's fatigue might be the proximal cause of a crash, but the corporate policy that forced them to work a 14-hour shift?
That's the root cause.
Right. So this legislation means a whole organization can be held criminally liable if their culture, their maintenance schedules, their training, if any of that leads to a death.
It broadens the forensic lens. You're not just taking a blood sample from the driver anymore. You're seizing maintenance records and corporate emails.
But for the clinician in the emergency department or the forensic physician at a police station, the focus is still acutely on that personal level.
Yes, and a massive part of that is intoxication. The limits of intoxication are highly testable material for you guys listening.
So let's look at alcohol. In England and Wales, the current maximum legal blood alcohol concentration for driving is 80 milligrams of alcohol per 100 milliliters of blood.
But from a physiological perspective, 80 milligrams is increasingly viewed as quite permissive.
Yeah, a lot of the world, including Scotland right next door, sets that limit much lower, usually at 50 milligrams per 100 milliliters.
And there is a hard clinical reason for that. The difference in a driver's state between 50 and 80 milligrams isn't just a rounding error.
It's statistically significant.
Highly significant. You see measurable degradation in reaction time, a narrowing of peripheral vision, and a loss of complex psychomotor skills.
And it impacts risk-taking, right, because alcohol is a central nervous system depressant, but initially it mimics stimulation.
Because it depresses the inhibitory control centers in the prefrontal cortex. At 50 milligrams, we start seeing delays in processing dynamic visual information, like a pedestrian stepping off a curb.
And by the time they hit 80, the risk of a fatal collision is exponentially higher.
Exactly.
Yeah.
The underlying principle is public safety.
Okay, let's unpack this further. Because while alcohol limits have been debated for decades, drug driving is this newer, much more complex frontier.
It is. The introduction of new drug driving laws in the UK, roughly between 2012 and 2015, created a highly specific two-tiered system.
Right. They split drugs into two categories, illicit drugs and medicinal drugs. And the legal philosophy for each is totally different.
It's a brilliant distinction, really. For illicit drugs, cannabis, cocaine, heroin, the law adopts a zero-tolerance or accidental exposure approach. The blood thresholds are set incredibly low.
So low that they're basically just confirming the drug is in the system.
Right. For example, the limit for THC, the active component of cannabis, is just 2 micrograms per liter of blood. Cocaine is 10 micrograms.
The goal isn't to prove the driver was actively hallucinating at 2 micrograms.
No, it's a zero-tolerance stance. You simply should not have these Schedule 1 substances in your system while driving. It saves the courts from wasting time trying to scientifically prove impairment at trace levels, which is a nightmare because tolerance varies so wildly.
But then we flip the script for the second tier. Medicinal drugs, prescribed medications like diazepam or methadone. The approach here is a risk-based approach.
Because society acknowledges that people have legitimate medical needs. Someone might need diazepam for anxiety, and they still have to commute to work.
So the legal limits are set much higher, where significant clinical impairment is actually expected to begin.
Exactly. Diazepam is set at 550 micrograms per liter in the UK, methadone at 500.
But this brings up a crucial framework for clinicians. You have to distinguish between simply exceeding a prescribed limit and the separate offense of driving while your ability is actually impaired.
Right. A patient could be under the 550 microgram limit for diazepam, but due to their age or a synergistic interaction with a tiny bit of alcohol.
They are profoundly impaired.
Yes. And this is where the medical assessment becomes paramount. When police stop a driver suspected of drug driving, they start with field impairment tests at the roadside.
The walk and turn, the Romberg balance test, the horizontal D's nystagmus.
These are excellent screening tools. They give the officer objective evidence to suspect impairment and make an arrest to request a blood sample.
But they lack a solid evidence base for evidential purposes in a courtroom, right? Like they can't identify the specific drug.
Exactly. They just tell you the nervous system is compromised. So the individual is brought into custody and a doctor is asked to examine them. And here is the absolute vital clinical pearl for you listening.
Listen closely to this part.
Your primary goal as a doctor in this scenario is not just to be a human drug tester for the police. Your job is to meticulously rule out underlying medical, neurological, or psychiatric conditions that mimic intoxication.
You are the safety net.
I cannot emphasize that enough.
Yeah.
A patient slurring their words and stumbling in a police cell might be drunk. Or they could be suffering from profound hypoglycemia.
They could be postictal after an unwitnessed seizure.
Or experiencing an acute stroke. Or, given we are talking about transport, they could have a slowly expanding subdural hematoma from a seemingly minor collision they had 10 minutes before the arrest.
If you dismiss them as just drunk, that brain injury could kill them by morning.
The clinical assessment must be rigorous. Vitals, pupillary response, Glasgow Coma Scale, blood glucose, and your clinical documentation will be scrutinized in court.
Speaking of documentation, you'll frequently see drivers who refuse to provide a breath or blood sample, and they'll offer medical excuses to avoid the penalty.
I have severe undiagnosed asthma. I can't blow into the breathalyzer. Or I have a needle phobia.
And while a few of those are valid, most are fabricated to evade prosecution.
And the courts rely entirely on your medical assessment to sort that out. If they claim asthma, did you auscultate a polyphonic wheeze? Did you measure their peak expiratory flow rate?
If they claim needle phobia, do they show objective autonomic signs of panic? Tachycardia, sweating. Or do they have visible IV drug track marks that contradict the phobia?
Your dispassionate medical findings are the barrier between a valid exemption and an evasion of justice.
Okay, let's transition from the driver to the biomechanics of the trauma itself. Section 2, pedestrian biomechanics.
This is a core forensic topic.
We are going to look deeply at impact kinetics, trajectories, and specific injury patterns. To set the scene, a pedestrian is crossing the street, a vehicle is approaching at speed. When the impact occurs, forensic medicine divides the trauma into a very clear conceptual framework.
Primary injuries versus secondary injuries.
Right.
Primary injuries are caused by the very first contact between the vehicle and the body. Secondary injuries occur when the pedestrian is accelerated by the impact and then decelerated by striking the ground, a wall, or another car.
And those primary injuries are an absolute goldmine for pattern recognition because their location is dictated almost entirely by the geometry of the striking vehicle.
Let's take a standard passenger car, a sedan. If a sedan hits an average-sized adult who is standing upright, the leading edge of the vehicle, the front bumper, will hit the pedestrian's legs at roughly knee level.
Which creates a highly characteristic injury, the bumper fracture.
Typically a wedge-shaped fracture of the tibia or fibula, often a Messerschmitt fracture. What's incredible about this is that the base of the bony wedge is at the point of impact, and the apex of the wedge actually points in the direction the vehicle was traveling.
The bone literally acts as a directional arrow for the kinetic energy. That is amazing evidence for crash investigators.
But the vehicles on our roads have changed. We have massive SUVs, transit vans, and 4x4s now.
And that changes the primary impact zone completely.
Right. If an SUV with a high, flat front end strikes that same adult, the bumper isn't at knee level. The primary impact shifts up to the pelvis, the abdomen, or the lower chest.
So instead of a broken leg, you're dealing with catastrophic internal bleeding from a disrupted pelvic ring or a ruptured liver.
And the trajectory changes. A low sedan sweeps the legs out, causing the pedestrian to drop onto the hood. But a high, flat SUV strikes right at the center of mass. It imparts all its energy into the torso, often knocking the pedestrian flat forward.
Meaning they get run over by the very vehicle that just hit them.
Exactly. So what does this all mean for forensic reconstruction? How do investigators link a hit-and-run vehicle to a victim?
It comes down to measurement. At the autopsy, the pathologist measures the exact distance from the sole of the victim's heel to the center of the primary impact injury.
Say, on the pelvis.
No.
And meanwhile, investigators at the scene measure the distance from the ground to the primary damage on the suspect car's grille.
And if the heel to injury matches the ground to damage, you have objective evidence linking the car to the victim.
Then we have to consider velocity. The speed of the vehicle dictates the cinematic trajectory of the body through the air. Let's look at the thresholds.
Okay, low speed impact, say around 20 kilometers per hour or 12 miles per hour.
The energy transfer causes bruising, maybe a simple fracture, but the body mass resists massive acceleration. They're usually just knocked down or pushed to the side. The injuries are localized.
What if we increase it? 20 to 60 kilometers per hour, 12 to 36 miles per hour, normal city speeds.
This is the classic scoop or wraparound trajectory. The bumper strikes the legs, accelerating them forward. The upper body pivots backward, wrapping around the front of the vehicle.
They slide up the hood, and their head or shoulders aggressively strike the windscreen or the rigid A-pillars.
The secondary impact with the car causes severe head and cervical spine trauma.
And then the high-speed threshold, greater than 60 to 100 kilometers per hour, 36 to 60 miles per hour, highway speeds.
The energy transfer is immense because kinetic energy increases exponentially with speed squared. The pedestrian is projected violently up into the air. They might be thrown completely over the roof, missing the windscreen entirely.
And when they hit the asphalt at that speed, the secondary injuries are devastating. Multi-system trauma, amputations.
Let's focus on the head trauma for a moment. A common misconception among junior staff is that a fatal head injury requires a massive skull fracture.
But the biomechanics of the brain dictate otherwise.
This is critical in neuropathology. The brain is a semi-solid mass floating in cerebrospinal fluid inside a rigid skull. In a high-speed impact, you do not need to break the skull to destroy the brain.
When the head is whipped around, the skull stops moving, but the brain keeps moving inside the fluid.
It experiences intense rotational and angular deceleration forces. It twists and glides.
And that twisting creates profound shearing forces at a microscopic level.
Yes. The gray matter and white matter have different densities, so they accelerate at different rates. This differential movement physically stretches and tears the microscopic axons.
The wiring of the brain, traumatic axonal injury, or TAI.
The shear strain disrupts the axonal cytoskeleton. Under a microscope with specific stains, you can see these swollen, damaged axons. TAI is devastating, it causes profound coma, and it frequently occurs with a completely intact skull.
The absence of a skull fracture never rules out fatal brain trauma. We also need to cover runovers. This is gruesome, but forensically vital. When the wheel actually passes over the body, Simpsons outlines two specific patterns. The first is flaying or a degloving injury.
Flaying happens when the heavy, rotating wheel passes over a limb. The friction of the moving rubber grips the skin.
And as it turns, it imparts a massive tangential shearing force.
It literally rips and strips the skin and subcutaneous fat away from the deep fascia and muscle. It destroys the perforating blood vessels.
Often creating a Morella Valley lesion, a massive hematoma in that sheared space.
And the second pattern is the tire tread injury. A literal patterned bruise mirroring the tire tread. But what's fascinating here is a counterintuitive biomechanical detail.
Right. Let's break down the mechanism of that bruising. A tire tread has raised blocks of rubber at the hills and empty grooves between them, the valleys. When that tire rolls over skin, what happens to the blood vessels?
The immense weight pushes the raised rubber hills into the skin so tightly that they squeeze all the blood completely out of the capillary beds in that specific spot.
The blood is forced laterally, pushed out from under the hills and into the uncompressed areas,
which correspond to the valleys or grooves of the tire. The capillaries in those valleys get a massive surge of blood and pressure, and they rupture.
So the dark intradermal bruising you see on the skin actually forms a perfect replica of the valleys, the negative space of the tire tread, not the raised parts.
Recognizing this negative space mirroring is crucial when matching the injury to a suspect's tire. If you read the bruise as the hills, you'll look for the wrong tire.
That is a phenomenal detail. The body acts as a negative space photograph. Okay, section 3. Inside the vehicle. Deceleration, occupants, and restraints. Most fatal collisions involve the front of the vehicle striking something solid.
Massive rapid deceleration.
Let's visualize an unrestrained driver. The car stops crushing, but the human body, obeying Newton's first law, keeps moving forward at the original speed.
We call this the kinetic chain. Think about the driver just milliseconds before the crash. They perceive the impact and instinctively slam their feet onto the pedals, locking their knees and bracing against the floor pan.
So their legs act as rigid struts.
When the impact occurs, the floor pan is aggressively driven backward, while the mass of the torso continues forward. That tremendous force travels straight up the locked leg.
From the talus bone, up the tibia, into the knee, up the femur.
And it violently drives the head of the femur right at the back of the hip socket into the pelvis,
resulting in severe posterior hip dislocations or dashboard fractures of the acetabulum.
Meanwhile, the unrestrained upper body flies forward. The chest hits the steering column, multiple flail rib segments, a transversely fractured sternum, direct contusions to the heart.
And the face hits the glass, which brings us to sparrow foot marks. What is the pathology here?
Modern windscreens are laminated glass, designed to crack in a spiderweb but remain intact. But side windows and older windscreens use toughened or tempered glass.
Heat-treated glass.
Right. When it breaks, it instantly shatters into thousands of small, relatively blunt, dice-like cubes. When an unrestrained face hits that shattering glass, those cubes strike the skin,
causing numerous small triradiate or Y-shaped superficial lacerations.
They look exactly like the footprints of a small bird tracking across the skin. Sparrow foot marks tell the pathologist the victim was exposed to shattering toughened glass, helping reconstruct their position.
Let's go deeper into internal trauma. The torn thoracic aorta. This is the classic deceleration injury. Why does it happen, and exactly where does it happen?
We have to conceptualize the anatomy. The descending aorta runs down the back of the chest cavity, tightly bound and fixed to the vertebral column. It is immobile.
But the heart itself and the transverse arch of the aorta above it are relatively mobile.
Exactly. Suspended in the pericardial sac. So biomechanically, you have a heavy, fluid-filled organ, the heart hanging off a pipe, the aortic arch that is rigidly bolted to the spine further down.
In a massive frontal collision, the rib cage stops abruptly against the steering wheel.
But the heavy heart keeps moving forward. This creates an immense acute shearing force at the exact transition point between the mobile arch and the fixed descending aorta.
And where is that exact fulcrum point?
At the ligamentum arteriosum, a small ligament tethering the aorta to the pulmonary artery, just distal to the origin of the left subclavian artery.
The forward momentum literally stretches and tears the layers of the aorta transversely at this specific junction,
causing catastrophic, almost instantly fatal internal hemorrhage. A transected aorta at the ligamentum arteriosum is the absolute hallmark of severe rapid deceleration.
This brings us to the safety systems engineered to prevent this. Occupant restraints, seatbelts.
A proper three-point seatbelt does three specific biomechanical things. First, it spreads the force over the strongest parts of the skeleton, the wide pelvis and the sturdy rib cage.
Force divided by area equals pressure. Increase the area, decrease the pressure.
Second, the webbing is engineered to stretch slightly under load. This artificially extends the time it takes for the body to decelerate. Increasing the time drastically reduces the peak G-force acting on the organs.
The principle of impulse.
And third, it restrains the body inside the protective steel cage, preventing ejection. Being thrown out exponentially increases mortality.
But seatbelts can cause injuries themselves.
Yes, the force is still immense. Seatbelt abrasions and pattern bruising across the neck and chest are common. Forensically, they are useful because the diagonal angle can definitively prove if the person was the driver or passenger.
But they can cause internal injuries if worn incorrectly, like if the lap belt is high over the soft abdomen instead of low across the bony pelvis.
During deceleration, it compresses the bowel against the spine, causing mesenteric tears or chance fractures, severe flexion distraction fractures where the lumbar vertebra is pulled apart.
And then we have airbags. An airbag deployment is essentially a highly controlled, localized explosion.
It relies on a chemical propellant, traditionally sodium azide. When accelerometers detect a crash, an electrical charge ignites the pellet,
producing nitrogen gas so rapidly that the bag deploys in milliseconds.
The bag has to inflate fully and begin to deflate through vent holes before the occupant's face reaches it. It must provide a yielding cushion, not a hard wall.
But there is a massive clinical warning here. Airbags are calibrated to save average-sized adults. They punch out at speeds exceeding 200 miles an hour.
They frequently cause severe friction burns, corneal abrasions, and impact trauma to adults. But the truly lethal danger is to infants in rear-facing baby seats placed in the front passenger seat.
If that airbag deploys, it strikes the rigid back of the infant seat with explosive concussive force.
It violently drives the seat backward into the backrest. This causes catastrophic, often immediately fatal basilar skull fractures or high cervical spine trauma to the infant, even in minor collisions.
Rear-facing seats must never be placed in front of an active airbag. Okay, Section 4. Exposed riders. High vulnerability transport motorcycles, pedal cyclists, micromobility.
The kinetics are entirely different here. The rider is immediately separated from the vehicle in a crash.
The body becomes the brake pad. The absolute hallmark injury of a high-speed motorcycle crash is the brush abrasion or road rash.
The friction physically grinds and burns away the epidermis and dermis. And forensically, the friction creates microscopic skin tags within the wound.
By examining the direction these tags are pointing, you can determine the exact direction the body was sliding across the pavement,
helping reconstruct the crash trajectory. Simpsons also highlights the tailgating or underrun injury,
a highly lethal mechanism.
When a motorcyclist or a low-profile sports car follows a heavy transport truck too closely, if the truck brakes suddenly, the rider slides directly underneath the high rear tray of the truck.
The lower body clears the undercarriage, but the rigid steel edge of the truck bed impacts the rider's chest or head at high speed,
leading to catastrophic blunt force trauma to the upper torso or devastating decapitation as the head is sheared backward.
But this is where forensic data directly influenced engineering.
Recognizing this pattern, many countries mandated the installation of strong drop-down metal bars, man-field bars on the sides and rear of heavy trucks.
These underrun guards physically block the rider from sliding underneath. It changes the injury pattern from fatal decapitation to potentially survivable thoracic trauma.
What about pedal cycles? The speeds are lower, but vulnerability is high. The most tragic pattern is the run-over injury involving turning lorries.
The blind spot scenario.
A cyclist attempts to undertake pass on the inside lane. A lorry stopped at a junction. They place themselves in the massive blind spot. When the lorry turns, the rear wheels cut the corner tightly,
sweeping over the cyclist, pulling them under, resulting in unsurvivable compressive injuries.
The text also brings up micromobility. Hoverboards, segways. The epidemiologic data is wild. Almost 25,000 ED visits linked to hoverboards in the U.S. in 1 year alone.
The inherent instability requires dynamic balance. When lost, falls are sudden.
We see complex orthopedic injuries, calls as fractures of the wrists, elbows, clavicles, as riders instinctively put their arms out. A foosh mechanism. Fall on an outstretched hand.
And significant maxillofacial trauma.
Simpsons includes a grim anecdote. Jimmy Hesselden, the owner of the Segway company, died after losing control of a ruggedized Segway and falling off a cliff. Gravity and momentum are unforgiving.
Section 5. High mass and high velocity. Railways and aviation. The sheer mass of a train means the kinetic energy transfer is absolute.
The trauma is massive, often resulting in severe mutilation and amputation. A railway death scene is incredibly complex. The body is scattered, heavily soiled by axle grease, covered in abrasions from the track ballast.
But there is still pattern recognition, differentiating suicides. Lying on the tracks versus jumping.
If an individual lies across the track, resting their neck on the rail, the train wheel acts like an industrial shear. The injury is often a highly localized, clean, crushed decapitation.
The rest of the body might be relatively untouched.
Conversely, if someone jumps from a bridge into the path of a high-speed train, the body is violently struck by the flat front, thrown, dragged, and rolled under the undercarriage. Whole body destruction.
But here is a critical point of forensic reasoning. You cannot automatically assume the manner of death was suicide or accident just because a body is on the tracks.
The vital question of staging. A perpetrator might murder someone via blunt force or strangulation, then dump the body on a railway line, hoping the massive train impact destroys the evidence.
How does a pathologist differentiate a staged scene from a genuine suicide?
We rely entirely on the physiology of vital responses. When a living person is injured, their heart is beating, so they bleed forcefully into tissues, creating expanding hematomas. The inflammatory system reacts, sending leukocytes. We can see this microscopically.
Pre-mortem trauma has a physiological signature.
Yes, if a person's already dead when the train hits them, that massive post-mortem crush injury will lack the characteristic severe bleeding and inflammatory response of a vital pre-mortem injury.
So you meticulously search for injuries inconsistent with a train impact. A depressed skull fracture on the back of the head, defensive stab wounds, petechial hemorrhages in the eyes.
If those show a vital cellular reaction, but the train crush injuries do not, you have proof they were killed before the train arrived.
The text also covers occupational hazards, the 600-volt electrified rails, and railway workers caught between the massive steel buffers of two train cars.
Massive lateral compression of the chest. This causes a flail chest, destroying the rib cage's mechanical integrity, and it causes traumatic asphyxia.
When the chest is suddenly compressed, the pressure inside the right atrium skyrockets.
The jugular veins don't have valves to prevent backflow. That massive pressure forces blood violently upward, back out of the heart, into the venous system of the head and neck.
Capillaries burst under the pressure, causing profound dark purple discoloration, massive swelling, and dense petechial hemorrhages in the conjunctiva and the face.
Let's shift to the skies. Aviation disasters. In a large commercial disaster, the forces are apocalyptic.
A pressurized metal tube at 35,000 feet at 500 miles an hour.
If the cabin loses integrity, passengers suffer extreme barotrauma from explosive decompression. If it strikes the ground, deceleration forces are beyond human tolerance, and the thermal trauma from aviation fuel fires is immense.
But the investigation of light aircraft crashes, Cessna's ultralights, has a different focus. The autopsy of the pilot is arguably the most important medical component of the investigation.
Because you have to determine the sequence. Did an engineering failure break the pilot? Or did a physiological failure in the pilot break the plane? The pilot is a biological black box.
The forensic pathologist must exclude 3 specific categories of impairment. First, natural disease.
Did the pilot suffer a massive myocardial infarction or an ischemic stroke of the controls?
Second, toxicology. Testing blood and vitreous humor for alcohol, illicit drugs, or impairing prescription meds.
And third, highly specific to light aircraft, we must exclude carbon monoxide toxicity.
Why is CO such a specific risk in a small plane, assuming there's no fire?
Engineering design. Many single-engine planes heat the cabin by passing outside air over the hot engine exhaust manifold before blowing it inside. If there's a hairline crack in that manifold, colorless, odorless carbon monoxide floods the cabin.
CO binds to hemoglobin with an affinity 200 times greater than oxygen, creating carboxyhemoglobin.
It displaces oxygen and causes a leftward shift of the oxygen dissociation curve. The hemoglobin refuses to release oxygen to the tissues.
The brain is starved of oxygen. The pilot doesn't choke. They become confused, lethargic, and fall unconscious at the controls.
If we find elevated carboxyhemoglobin in a pilot's postmortem blood and the classic cherry red lividity, it definitively proves the crash was caused by an engineering failure of the exhaust system, not pilot error.
Section 6, the marine environment. Water transport fatalities bring drowning, rapid hypothermia, and blunt force trauma.
Recreational sailing injuries are surprisingly violent. Heavy, rigid booms swinging across the deck during a sudden wind shift cause severe blunt head trauma or cervical spine fractures.
Digits lost in spinning winches or propellers. Friction burns from synthetic ropes stripping tissue to the bone.
And operator inattention, lack of life jackets, and alcohol intoxication are massive factors in fatal capsizing. Impairment on the water degrades judgment, reaction time, and physiological survival in cold water.
The text throws in a specific point about marine life trauma. Shark attacks in U.S. waters.
Statistically rare, but fatal interactions are most linked to swimming or surfing rather than boating, sustaining 3 or more separate bites or suffering significant limb loss, which occurs in about 7% of recorded attacks. Cause of death is massive exsanguination.
Finally, commercial marine hazards. Container ships, oil tankers, massive kinetic trauma from shifting cargo, and a particularly insidious hazard, asphyxiation in confined spaces.
When workers enter enclosed storage tanks or cargo, holds that lack ventilation. The space might be depleted of oxygen due to rusting steel or filled with toxic, heavier-than-air fumes like hydrogen sulfide gas from decaying organic cargo.
The worker takes 1 or 2 breaths, experiences the knockdown effect, and loses consciousness immediately.
In the UK, these are investigated by the Marine Accident Investigation Branch, applying rigorous scrutiny.
Wow. We've covered a massive amount of ground today, from microscopic shear strain on a neural axon to systemic corporate liability. Let's pull all of this together.
If we synthesize this chapter, the core clinical takeaway is this. In transportation fatalities, the human body acts as a highly detailed biomechanical record. The patterns of injury strictly reflect the physical position of the victim, the velocity and geometry of the impact, and the use of restraints.
Toxicology is central to understanding the human element, and your physical scene reconstruction must perfectly logically align with your objective autopsy findings.
You cannot accurately interpret one without understanding the other.
Let's lock this knowledge in. It is time for our clinical recall wrap-up. I am going to throw out a single best answer prompt. I will pause for exactly 3 seconds to let you, the listener, lock in your answer. Then our expert will break it down. Ready? Let's go. Prompt 1. A pedestrian is struck by a vehicle and projected over the roof. What was the likely minimum speed of the vehicle? 3, 2, 1.
Greater than 60 kilometers per hour or 36 miles per hour. Revisit pedestrian biomechanics if you missed that.
Prompt 2. In a severe rapid deceleration road traffic collision involving a frontal impact, where anatomically is the thoracic aorta most likely to transect? 3, 2, 1.
Just distal to the origin of the left subclavian artery, at the ligamentum arteriosum. This is the fulcrum where the mobile arch meets the fixed descending aorta. Revisit inside the vehicle.
Prompt 3. During a forensic autopsy of a run-over victim, intradermal bruising from a tire tread is found. Where does the bruising form relative to the physical structure of the tire? 3, 2, 1.
In the valleys or empty grooves of the tread pattern, not under the raised hills. The hills squeeze blood laterally into the uncompressed valleys, where vessels rupture. Revisit pedestrian biomechanics.
Prompt 4. What 3 critical factors must a forensic autopsy of a light aircraft pilot specifically exclude to rule out pilot impairment? 3, 2, 1.
Natural disease, drug or alcohol intoxication, and carbon monoxide toxicity from a faulty exhaust system. Revisit aviation.
Prompt 5. Under the 2015 UK drug driving laws, how does the legal philosophy differ when prosecuting the presence of an illicit drug versus a medicinal drug? 3, 2, 1.
A zero tolerance or accidental exposure threshold for illicit drugs, and a much higher risk-based threshold for medicinal drugs balancing therapeutic need. Revisit transportation under the influence.
Excellent work. As we wrap up, we want to leave you with the final clinical perspective.
When we look at this sheer volume of trauma, from pedestrian impacts to marine accidents, we see that the vast majority are deeply mathematically predictable based on physics and anatomy.
Which raises an important question.
If these injury patterns are predictable, they are preventable. How can the meticulous forensic data you document today drive the public health policies and vehicle engineering standards of tomorrow? Mansfield bars and laminated glass didn't happen by accident. They happened because clinicians documented the pathology of failure.
Your precise documentation is the first necessary step in saving the next life. A phenomenal perspective. Be sure to read Chapter 19 of Simpson's Forensic Medicine to fully cement these details. Thank you for joining us on this deep dive. Keep questioning the evidence, keep learning the physiology, and we will see you next time.